today I'll be talking about the less common approaches to the hip joint. It's really interesting, having done a review of all the historical terms and descriptions of hip replacements, approaches, and other approaches to the hip, that when you don't have a good access via one approach, that there's always another way of going around it. Today we'll be talking about the posterior acetabular approach and the surgical hip dislocation as combined, the medial approach to the hip, and then finally the superior approach to the hip. I'm sure we're all very well versed on the three major approaches for hip replacement: the anterior and the anterolateral, and the posterior approach, so we won't be going into detail with those today. So the first one to talk about is the posterior acetabular approach and the surgical hip dislocation. This is an approach that's used for acetabular fractures, femoral head fractures. It was originally described by Ganz for using femoral acetabular impingement, and sometimes in pediatric centers it will be used for realignment of adolescent slipped femoral epiphysis. It's an extensile approach, and its preservation of the femoral head is the most important part of this approach. It's more commonly used at trauma centers and pediatric centers, as I mentioned. A lot of different terms are used. More commonly, particularly in Victoria, we use the term Cocker-Langenbeck approach when we're describing an approach to the posterior acetabulum. And then we use the term Ganz to describe a surgical hip dislocation. Now, where do these terms originally come from? So Langenbeck was first described in 1874, and Cocker describes his variation of the Langenbeck, so it was never published together, in 1892 in the textbook of operative surgery. Gibson then took the approach in 1950 and modified it. McCarthy is the first person to describe a trochanteric osteotomy in 1972 for a surgical hip dislocation, and Ganz published in large numbers of the surgical hip dislocation from then on. So today we'll be really talking about the Ganz approach to the surgical hip, with a few variations talking about how do you access the posterior acetabular wall and column. So the posterior acetabular approach to surgical hip dislocation, you position the patient in the lateral position. The skin incision is a curvy linear incision centered around the GP. Superiorly, it's extended towards the SIS, and inferior along the longitudinal axis of the skin. Superficially, fascia, extend that along the skin incision. ITB along the femur. So we have two options here, depending on what part of the acetabular femur you want to access. When it comes to a posterior wall, we need to take down the piriformis and obturatus internus tendon, or the conjoint tendon, and we divide that 2 centimeters medial to its insertion in the femur. That's the main difference compared to when we do a posterior hip approach for a total hip replacement, as dividing it 2 centimeters medial protects the medial femoral circumflex artery. The other key point is to spare quadratus femoris. The other option is when we want to extend anteriorly and superiorly. So that can be used routinely in a posterior acetabular approach, but is mainly more important when we're talking about a surgical hip dislocation. And this is the greater trochanteric osteotomy. We leave the abductors and vastus lateralis to this PC osteotomize, and we slide it anteriorly. Next is the capsulotomy, which is a Z-shaped capsulotomy, which we'll show you some diagrams in a moment. The main dangers in this approach are the sciatic nerve and the medial femoral circumflex artery. However, when operating around the pelvis, it's possible to damage many other structures nearby. So this is a picture from 1907. This is the first English translation of the Langenbeck approach, Cocker approach, which was the variation of the Langenbeck approach. And this was actually originally described for a resection of the hip joint. So there was no talk about preservation of the blood supply to the hip joint. Now, this is a diagram demonstrating the differences between the Langenbeck approach and the Gibson approach. So the red line is what was described by Cocker, which is going superiorly through the muscles of glute max, whereas Gibson wanted to keep all of glute max muscle in one, so he drifted his superior limb more anteriorly. The diagram to the right demonstrates where you would consider doing your tenotomy of piriformis and the conjoint tendon, and so it's 2 centimeters medial to the attachment into the femur. The next diagram is from Gantz's original article talking about the trochanteric osteotomy, and he talks about keeping gluteus medius and vastus lateralis. The main important part of this trochanteric osteotomy is to leave piriformis, the conjoint tendon, and capsule. In a different variation of Gantz's article, he's described it at least 3 times. He does talk about even leaving some gluteus minimus on to really protect that capsule and the blood supply, and then reflecting gluteus minimus separately. This is an original, another other part of that is to talk about the capsulotomy. So I'm not sure if you can see the mouse, but the capsulotomy, the blood supply to the medial femoral circumflex artery extends posteriorly and then goes along the superior margin of the neck. So it's important to make your longitudinal, the transverse part of the capsulotomy slightly more anteriorly. And when we extend it posteriorly, that's part of the superior limb. And then when we extend it on the femoral side, there we can do that a bit more inferiorly. So it's Z-shaped capsulotomy. This is Gibson's article, which he also talked about a surgical hip dislocation, and he did a U-shaped capsulotomy. This is a diagram demonstrating the blood supply of the medial femoral circumflex artery. It extends posteriorly along the neck around the trochanteric ridge, and then extends superiorly. So we really want to make sure that when we do our capsulotomies, demonstrated by this picture, that we're trying to make this part as anterior as possible while still maintaining an exposure of the femoral head. The main concern with doing this approach is avascular necrosis, and Gans has published twice on this, once in 2013 and 2015, demonstrating a 6.5 and a 7.7% risk of AVN with a minimum follow-up of 24 and 26 months. There are some other articles which show a slightly higher risk of AVN. The next approach we'll be talking about is the medial approach to the hip. So this is commonly used in open reduction of DDH and Lysosomas, so it's mainly done at pediatric centers. The three main types are a Weinstein, a Ludloff, and a Ferguson, but today we'll be mainly talking about the Ludloff, or at least the Victorian variation of the Ludloff. So this is an article from the Royal Children's talking about a ligamentous tenodesis and the medial open reduction of a DDH hip, and it describes their approach in detail. Then you're positioning the patient, we position the patient supine with the hip flexed, abducted, and externally rotated. We do a 3 to 4 centimeter incision parallel and 1 centimeter distal to the groin crease. There's other talks about 3 centimeters distal to the groin crease, but obviously that depends on the size of your patient. This approach has also been described with a longitudinal incision as well. Superficially, the adductor longus is divided close to the pubic tubercle, as this is also a deforming part of a DDH hip. The obturator nerve anterior branch is identified and protected, which lies anterior to adductor brevis. Deep structures is now moving between pectineus and adductor brevis. We feel for the lesser trochanter, and we should be able to visualize and protect the medial femoral circumflex artery. The psoas tendon is divided at its insertion here. A T-shaped capsulotomy is performed, and then other additional parts of the reduction of a DDH hip are performed. The main dangers here include the obturator nerve, so predominantly the anterior branch that lies on anterior to adductor brevis, the femoral neurovascular bundle, which is on the other side of pectineus, and then the medial femoral circumflex artery that we're protecting. Additional steps in this approach include dividing the transverse acetabular ligament, a capsular plication, and a ligamentum teres tenodesis to the transverse acetabular ligament stump. These are some pictures demonstrating from the Royal Children's article, demonstrating their capsulotomy as well as the approach. And in Hoppenfeld, they've described a more extensile longitudinal incision to the medial femur. Now, the main other concern is with this approach is also avascular necrosis because the medial femoral circumflex artery is in close proximity. Obviously, in DDH hips, there's other causes for AVN. But in a 10-year follow-up with these 43 patients, there was only 16% radiological evidence of AVN and an 89% good or excellent Severin grading, which is a marker of DDH. Finally, we'll be talking about a superior approach to the hip. Now, this is really only a variation on the posterior approach, and other articles demonstrating a mini posterior approach is almost exactly identical with the superior approach to the hip. The main philosophy of this is it's an ITB sparing approach, and there's a potential for less trochanteric pain. This is described in 2001 in the JBJS. Position is lateral, just like a posterior approach. Incision is about 8 to 10 centimeters at a 60-degree angle posterior to the line of the femur, commencing inferiorly at the GT and not drifting inferiorly to the top of the GT. Superficially to the fascia, it's through gluteus maximus and ITB is spared. Deep Then again, we're going back to a posterior hip approach. So piriformis and obturator internus is divided, Rotatus femoris is preserved, and there are various capsulotomies that have been spoken about. The main requirements of this approach is that an offset ream is important because your anterior exposure is less, and it requires an assistant to posteriorly translate the femoral shaft, so to deliver the femoral shaft through the gluteus maximus to allow for broaching the femur. And as always, the danger is a sciatic nerve. The main thought and philosophy is that if the ITB is spared, then less lateral hip pain might be experienced. So really, however, is the superior approach and the superior approach. In a journal of arthroplasty comparing these two approaches, between a mini posterior approach and a superior approach, there's no difference of pain, either anterior, groin, or lateral hip pain in this approach. Unfortunately, there aren't any studies comparing two different approaches that demonstrates the superiority of the superior approach at this stage. I'm sure as more numbers, there'll be more research and data to confirm or deny. That concludes my talk.